Next, we have Dr. Abhishek Dave, who would be giving some pearls on management and diagnosis of HSV epithelial keratitis.
Yeah, so good morning everyone, and coming to the first clinical presentation of HSV, so I'll be talking about HSV epithelial keratitis. So HSV epithelial keratitis can be classified basically into two types, the infectious epithelial keratitis and the neurotrophic keratopathy. And infectious further can be classified into corneal vesicles, dendritic ulcers, geographical ulcers and marginal ulcers. So we will be discussing them one by one. Symptoms and signs, coming to the symptoms, they are basically same as for any corneal ulcer. So there will be photophobia, there will be pain, epiphora and decreased vision. The earliest lesion is small raised vesicles on the epithelium and they stain negatively initially, and later they coalesce to form the typical dendritic ulcer. So coming to the main presentation of HSV epithelial keratitis, so this is the typical dendritic ulcer, which comes from a Greek word dendron meaning tree. So as with the tree, there are branching linear lesions with terminal bulbs. So these terminal bulbs are very important to note because they would be helpful in differentiating them from the other pseudodendrites. The swollen border of these lesions have the live virus. So this is one of the HSV condition where a live virus is present on the eye. Coming to the staining pattern of a dendrite, so they stain positively with fluorescein stains. So if you see the base of the ulcer, that will be staining darkly green with the fluorescein. The epithelial borders stain negatively, though the epithelial borders, if you stain, would stain with a rose Bengal dye. So this is also known as double staining, where the borders stain with the rose Bengal dye and the base stains with the fluorescein dye. So how do we differentiate dendrite from other non-HSV causes of pseudodendrites? So this is one example of HZO or herpes zoster pseudodendrites, where we see the dendrites are very shallow, they are very thin, and they are no terminal bulbs. So that is an important thing. Other conditions which can lead to a dendritiform lesions could be toxic medicamentosa, so where a lot of medications can cause an ocular surface irregularity. Also, at times, epithelial defects, when they are healing, can give the shape of a dendrite. So the next presentation can be a geographical ulcer. So if a dendrite is left for a long time untreated, or if it's treated wrongly with steroid, then it can lead to a geographical ulcer. So basically these are enlarged non-linear dendrite. So if you see, this area has become much more thickened than a typical dendrite, and these are still dendritiform. Important to note are these scalloped edges which would be there. Coming to the marginal ulcer, so these are basically epithelial ulcers with stromal infiltration. So there's an intense limbal injection, and these patients are also more symptomatic than dendritic keratitis, and they ultimately progress centrally as dendrites. What can differentiate it from a staphylococcal marginal keratitis is that there is no lucid interval, they are bang on the limbus, and also they can be on other positions apart from the routine 2 and 7 position. So an epithelial keratitis can lead to dendritic epitheliopathy, which are basically non-ulcerated healing dendrite. It can lead to stromal scarring and ghost figure. And important to note is that almost 1/4 of patients can land into a infectious or immune stromal keratitis as the epithelial keratitis is going away. Another presentation of HSV can be a neurotrophic keratopathy, which is basically due to impaired corneal innervation and decreased tear secretions. There is an irregular epithelium and an oval epithelium defect with a smooth thickened border. So here you have to note that the borders are smooth and thickened as compared to a geographical ulcer where they were more scalloped. Coming to the treatment of these conditions, so the mainstay of treatment of a dendritic or a geographical ulcer is topical antiviral agents, as Dr. Akanksha also mentioned, and that is mainly based on acyclovir 3% ointment or ganciclovir 0.15% gel. They typically bind to the DNA polymerase and act like a chain terminator. Ganciclovir though is better tolerated with similar healing rates, but we still prefer acyclovir as the first line drug. And the aim of treatment here is to get rid of the infectious live virus. So typical topical therapy for a patient would consist of ointment acyclovir 3% 5 times a day, topical cycloplegics to prevent the ciliary spasm and pain, Broad spectrum antibiotics only add if there's a large geographical ulcer. Otherwise, for routine dendritic ulcer, you do not need any antibiotics. And lubricating eye drops, again, if the patient is very symptomatic, you can add, but has no definite role. Also, one thing to mention is that people have treated dendritic keratitis also with only oral acyclovir 400 mg 5 times a day. That can be done, and the healing rates are exactly the same as topical therapy. Only concern would be the systemic issues and the cost concern. Otherwise, healing rates are same. So where we would like to treat a patient with oral acyclovir for a dendrite would be compromised ocular surface, patients who are intolerant to topical acyclovir, and it can also be supplemented in cases like one-eyed patients or precious grafts. There one can consider supplementing oral therapy as well. Duration of treatment usually would be the loading dose 5 times a day should be for 5 to 7 days, and once the epithelium starts healing, you can reduce it to 3 times a day for another week or so. Longer periods may be needed for a geographical ulcer. So this is the patient with geographical ulcer. Acyclovir ointment was started. The epithelium started healing at about 1 week's time. This is the picture, and at 3 weeks time the epithelium has completely healed up. So what happens if a dendrite is not healing? It can be an incorrect diagnosis, so you have to reconsider the diagnosis. It can be drug resistance, which is very rare in less than 5 to 10% cases, but if this is the case, then you can observe, because dendrites may be self-healing also, or you can change to oral agents like foscarnet, famciclovir, or it can be an HSV dendritic epitheliopathy, which is basically a healing ulcer, so you just have to reduce your antivirals to reduce the toxicity. So topical corticosteroids are absolutely contraindicated for an active dendritic keratitis. So once you have started topical antivirals, and if you feel the patient is now going into stromal keratitis, there's stromal infiltration, like in this patient post PK, there is a lot of stromal keratitis developing with the dendrite healing. There you can add low dose topical steroid like fluoromethalon 3 to 4 times a day. Coming to neurotrophic keratopathy, so the basic treatment here is to stop the topical antivirals, add preservative-free lubricants 1 to 2 hourly, and a temporary tarsorrhaphy works wonder in such cases. Like this patient with PED post HSV keratitis, a tarsorrhaphy led to the healing of this defect, which was not healing for over a month on medical therapy. And a patient with neurotrophic ulcer, again the epithelial defect healed about in 20 to 25 days here. What about prophylaxis? So Dr. Akanksha has mentioned that as such oral acyclovir is not needed, but if there's a frequent recurrence of epithelial keratitis, then you can add 400 milligram acyclovir 2 times a day, probably for the lifelong period, because the effect goes away once you stop the acyclovir. So, thank you so much.
So I just had one question for the panelists also, that in some of these cases we do see certain scars in the visual axis post-epithelial keratitis. So what do you recommend starting topical steroids then, and is it something that a general ophthalmologist should do on its own, because they have to be sure that there is no presence of a live virus then?
So if there is no epithelial defect that you are seeing when the healing has completely taken place, and there is a slight infiltration in the anterior stroma, we often see these types of cases. In that scenario, low potency steroids first of all are needed. You don't need prednisolone acetate because it's very superficial, and the penetration of low potency steroids would also be sufficient. But the important thing is to keep the patient on antiviral prophylaxis when you have kept the patient on steroids. So even if the epithelial lesion has healed, the antivirals need to continue if you are adding a steroid. So that would be.
And just for scars, probably one should not start. But as Dr. Vikas mentioned, if there's stromal infiltration, then yes, it does reduce the scarring.
Thank you, Dr. Dave, for simplifying HSV epithelial keratitis.